started because I know you're anxious to hear him and not me. Dr. Chepke is a board certified psychiatrist that I mentioned earlier. He has a special interest in movement disorders and neuropsychiatric conditions with people with Parkinson's, and he and I have talked quite a bit, and he has a real passion working with people with Parkinson's. So we're excited to invite him, and I'm going to let Dr. Chepke talk a little bit about his background, how he got into working in movement disorders, and then he can start sharing his wealth of information. Dr. Chepke, welcome.
Thank you so much. And I'll go ahead and put the slides up so that way you can see my name and then once we get into the actual slides, of course. All right, so yeah, as Anissa said, I'm a psychiatrist, and I actually heard somebody say he's a psychiatrist. You may be wondering, why on earth are they bringing a shrink in to talk to a group of people and their loved ones with Parkinson's? And I agree. When I give these talks locally and in other venues, then oftentimes that is the question that people tend to have at first. But I think you'll come to see as I go throughout the presentation just how valuable having a psychiatrist as part of the team can be. So this is a slide that has the image. It might be familiar to you if you've browsed the PMDA website a bit. I took it from them. It does say that it needs PMDA approval, and I received that about 30 seconds before the broadcast went live. So this is an authorized use of that image. So, you've heard the saying, it takes a village to raise a child, but it really takes a village also to take care of someone and their care partners with Parkinson's. Parkinson's is such a vast and complicated and confusing illness, really, that there's a lot of different specialties can be involved. And there it is. You can see, yes, in fact, that I put the little red line around it, that psychiatry is part of that larger picture. So let's start talking about how psychiatrists maybe could be beneficial in the treatment plan for someone in general, and then we'll merge that into the topic of the family dynamics in Parkinson's as we go along. So again, this is probably another familiar image that many of you may have seen before. There's many variations of it. This one that I chose really, I think, highlights just some of the parts of Parkinson's that you might not think of initially. And honestly, I wasn't really taught in med school. In med school, I was taught the 4 things that were above that waterline. We use the acronym TRAP: tremor, rigidity, akinesia, and postural instability. But as all of you out there know by this point, there's so much more to Parkinson's than just that. If only it was that easy. If those were the only 4 symptoms of Parkinson's, I think most people would say they'd be set. And that's, I think, because the neurologists these days have gotten so good at treating the motor symptoms that to me seems to no longer be the limiting factor in someone's quality of life. It's really those non-motor symptoms that lie below the surface, that those tend to be the weak link in the chain of what is bringing down someone's quality of life with Parkinson's. And then obviously the ripple effect out to the rest of the family as well. So if this slide is a little bit scary to you at first, oh my gosh, look how many of those symptoms there are. And, odds are you probably are experiencing those, or your loved one is already. You just may not have been able to make that connection that this is part of Parkinson's. And that's something that I think is, it's due to a lot of factors. The visits with neurologists, they have to see so many people. There's, especially the movement specialists, there's so few of them that they don't have enough time to really talk with you about every single thing that's going on with Parkinson's. They cover a lot of things in the sessions. It's not like you're not doing good work in those visits, but there's just so many more things. So it really takes a whole team approach, an interdisciplinary team approach. And, and as I said, she's a social worker. My wife is a social worker as well. So, I've always kind of had that really team interdisciplinary approach to treating people in general, no matter what the condition is, but Parkinson's certainly is one of them. Because for all that we do know about Parkinson's, there's still a lot that we don't know, obviously. Organizations like the Michael J. Fox Foundation and many others are doing some fantastic research, and we're learning more every day, and new treatments are being developed. But really, I think we, in many ways, are kind of like this diagram that we're all blind people fumbling in the dark trying to describe what this illness is. And so what I can bring to the table as part of the team is very different in many cases than what a neurologist can bring, and internists. And ENT and all the other specialists you see there. But to get the full picture and really get the best quality of life, you might need to involve a number of the people that are in this diagram. So, and even the last slide that I mentioned before, I could probably give, well, I know I could give a whole lecture just on the non-motor symptoms of Parkinson's, but I wanted to kind of move quickly through that because I want to really get to the heart of the presentation, which is the way that the symptoms of Parkinson's and the diagnosis affects the family dynamics and relationships. So moving on to that, there's obviously a lot of them, and we'll start with romantic relationships. And there's just a number of different ways that Parkinson's might affect these kind of relationships that you may not have thought of, but think about how we communicate with each other. It's clearly so much more than just the words that we're speaking. There's the body language that we use and the facial expression. And of course, the motor symptoms of Parkinson's can have a severe impact on that. If there's bradykinesia, rigidity, then and the postural changes that people with Parkinson's have, the masked face that can reduce the facial features. We rely so much on the facial features and expressions to be able to determine how did that person react when I said this or that? What was their initial look on their face? And then how they respond. The speech, as many of you might have experienced, then speech can be quieter and lack the tonality. So, if I say something that I think is exciting to my wife and she responds back with monotone, I'd be dejected. Oh my gosh, I thought she'd be excited about that. I thought she'd realize how much that means to me. And with Parkinson's, that can really be all thrown off, that we may not be able to tell. Is it just that their medication isn't working very well for them right now and they can't really express themselves? They can't have the body language to get up and pump their fist and cheerlead for us like they normally would. And that can introduce some friction into some of the relationships and kind of plant some seeds of uncertainty in how you're interacting with that other person. And also cognitive symptoms of Parkinson's. One of the very prominent non-motor symptoms that one of the common ones that I see in my practice certainly are that the word finding is difficult. Another term for it is the tip of the tongue phenomenon. The person feels like they've got the word right on the tip of their tongue, but they just can't get it out. And so many of my patients have explained that sometimes they just don't talk that much because of that, or that because their speech is slower, then they don't want to take forever and waste people's time is a quote that I've heard in getting through that entire process to get their thoughts out. So they just kind of keep it to themselves. And then communication withers if we aren't able to actively tend it. And then in terms of the emotional intimacy itself, it can be difficult to wear many hats in a relationship with Parkinson's. If you're a care partner, sometimes you need to have the care partner hat on, but sometimes you need to take that off and have your spouse, your lover hat on. And sometimes that can be a difficult transition to navigate. It's not as easy as being able to flip a light switch sometimes for people, and they might get stuck in the care partner role and have a hard time going back to just being this person's partner and being emotionally present with them by no fault of their own. They just get stuck in a habit like everyone does. And then also holding things in. This could apply to either the person with PD or the care partner. Often I'll use the term my Parkinson's families because there is no such thing as one individual with Parkinson's disease that exists in a vacuum. There's always more people involved. And in a lot of my work with people with Parkinson's, after working with them for some period of time, whether it's a couple months, a couple years, then oftentimes I don't really have to change any meds anymore. And it ends up just being family therapy, couples therapy, things like that. So holding things in, that they're afraid that, well, I don't want to say anything. They're dealing with so much already. I'll just keep my worries and concerns to myself. And again, that can go both directions. And without that free-flowing lack of openness and forthrightness, that can damage the emotional intimacy of a relationship. And apathy is another very significant non-motor symptom. And it's different from depression. Certainly there's depression in Parkinson's disease, but apathy is different. And so the person may just lose interest in some shared hobbies that the couple used to really bond over, and they defined maybe much of their relationship with sharing those particular hobbies. the person who does have the PD may kind of fall away from that, and they lose those touch points that they can connect with each other emotionally when that happens. And then of course there's physical intimacy as well, which is, I think the pulse and the lifeblood of every relationship really. So sleep disturbances are very prominent in Parkinson's. One that when I do these kind of talks seems to resonate with a lot of people is that they end up oftentimes not even being able to share the same bed because of the sleep disturbances. There's something called REM behavior disorder, where the person with PD acts out their dreams. They can yell out or punch out, kick out, things like that physically as a result of the Parkinson's. And so their care partner may not be able to share the same bed with them. Number one, just because they may not be able to get a decent night of sleep themselves, but also in some cases to protect their own physical well-being. That if their partner is striking out at them unintentionally while they're sleeping, they can end up with bruises or knocked out of the bed altogether. And that's always is accompanied by such sorrow when people tell me these stories that they haven't been able to sleep in the same bed as their spouse for years. And it really is difficult to hear those kind of stories. And it's unfortunately very common. So Parkinson's itself can also cause sexual dysfunction. That's one of the non-motor symptoms that I'd say probably definitely your neurologist hasn't asked you about, I would guess, having known a lot of neurologists in my day. That's an uncomfortable one to talk about for most healthcare providers, but it's extremely important, again, to discuss that. And Parkinson's, the whole gamut of sexual dysfunction can happen, whether it's with arousal, the ability to perform sexually or to get sexual satisfaction. Any or all of those could be impaired directly by the Parkinson's. And then also medications. Medications could go either way. Some meds, especially some antidepressants, will have sexual side effects, but sometimes in Parkinson's, it can go the opposite way too, that many of the dopamine stimulating medications can cause impulsivity and obsessionality and hypersexuality even. And that, well, and I've had couples, depending on who you ask, that might be a good thing or a bad thing. But certainly it's a bad thing if it's not about the person who is their partner. And unfortunately, that is something that I've seen, that impulse control issue and hypersexuality can take the person somewhere to situations that they never would have gotten in before being on that particular type of medication. So you can see just one slide here, and this is actually probably the busiest slide I have because I do want to spend the bulk of our time with questions. I'm seeing them on the side of the screen really rolling in. So it's only about a 10 or 11 slide total that I have. But just already, I think you are starting to get a picture for really the vastness of the difficulty that relationships can have in Parkinson's. So a little bit more about that couple relationship. That they always say opposites attract, and that tends to be true, not just in personalities, but also in the strengths that each person brings to the relationship many times. Oftentimes there will be one person who is clearly more of the breadwinner than the other, one person who does the finances much better than the other, and those are often not the same person. That's definitely the case in my marriage. I may be the breadwinner, but I am not the financial wizard. I'm the financial bonehead. So, we truly do make each other better. And, hopefully most couples do complete each other that way. But then other ones, the meal planner, the cook, oftentimes one person can take on the bulk of those duties. The social butterfly. Sometimes there's one partner who always plans the social calendar. And if it weren't for him or her, then they would just sit around and not have that many interactions. And also the decisive person who, whenever there's a decision that needs to be made, one partner steps up, takes the lead, and brings the other partner along with them. But what if the Parkinson's takes away the abilities to fulfill those roles that the person used to have the strength in the relationship? And the other partner doesn't have that strength or hasn't developed it? That can be a really difficult situation. So one that I encounter commonly is that financial wizard thing, that the person with PD had been the one who had always done the taxes, paid the bills, and then for a variety of reasons, including cognitive difficulties, they're no longer able to take that on. They're making errors with taxes or balancing the checkbook, or they forget to pay bills because of the memory problems that they have. And then the other person starts to worry, well, how am I going to do this? I've never been good at that. I was never a math person. Things of that nature. And that applies to each one of those. And so Parkinson's can really introduce a lot of destabilization of what had been a very harmonious pairing in the past in just a number of ways. And then the last larger bullet point down there, that these kind of disturbances can leave the other partner feeling lonely or frustrated. They might feel like, as I said, they're holding things in and they can't talk to the other person who had been their best friend maybe, and now they just don't know who to talk to, and they feel alone. Even they feel lonely, even though they're not technically alone, and it can be a very heartbreaking situation. And once you start adding up, there's an emotional disconnect, a communication disconnect, a physical intimacy disconnect. Sometimes that can all spiral in a difficult direction. And believe me, this talk is not all gloom and doom. There are things that can be done about that. And we're gonna get to a lot of those things coming up in just a few minutes. We haven't even talked about children yet. Children always, no matter what the situation, introduce a lot of complexity and strife into our lives, right? Difficult, but they're worth it. But how do you navigate that with Parkinson's? So there's a couple of situations. There's the early onset person who might have young children themselves, and they have a significant role to play in the parenting of that child. And because of physical issues that they might be having, cognitive issues, emotional issues, similar to what we talked about with the couple relationships, they may not be able to fulfill those roles the way that they wanted to. Had people who said, my whole life, all I wanted to be was a good dad. And now I can't go out and play football with my son. I can't go and toss the ball around with my daughter because I'm just too slow, and I've got pain and a number of other issues, or I just can't help them with their homework. It might just be 7th grade math, but I can't do it. I can't think fast enough. It can be very difficult, and kids have a hard time with that sometimes. At the very last slide that I have is a little short case studies contained within just one quote. Various quotes that some of my PD families have said throughout time, and one of them is from a young onset person who has now an adult child. She's just turned about 20 years old, and but what she always said was, I wish I just had a normal mom like all the other kids. And so you can see this is truly a multi-generational, widespread issue that it's like an onion. The layers keeps getting deeper and deeper the more we talk, right? And then once the children do get to be adulthood, well, then they might come into conflict with the spouse who might be the primary care partner. Maybe the children want to step up, and they might not agree with the decisions that their parent, who's the care partner, is making about the person's with PD's care. Or it might be the other way around. That it could be that the care partner, well, they still see the child as a baby, and even though they're a fully grown adult, they might have their own family now. Well, they're just a kid; they don't know anything. That well, just like in any kind of parental situation, when there is that sort of attitude, the kid is gonna buck up against that, right? But then the stakes do seem to get higher when you add the Parkinson's into the mix. And then if there is an adult, a child who is one of the primary care partners, maybe not the sole, but one of the primary, then they may feel torn with loyalty to their parent with PD to help take care of them, but then they've got their own family too, and how do they balance that time? That they just feel like they don't have enough hours in the day because of being pulled between their new family and trying to be a good care partner for their parent with PD. So, and again, I'm moving through these fast so we can get to the Q&A. I think it is actually illegal to have any sort of presentation about anything in 2020 without having a slide on COVID. So I'm checking that box right here. And it is very important though. I'm sure there's probably been a lot of webcasts that people in the audience have seen that are on this topic alone. And just some of the ones that I've seen in my practice that we all know how good exercise is for Parkinson's, the only disease-modifying treatment that we have for PD at this point. And sure, you can still go and get some exercise in your house and maybe go for a walk that's socially distanced. But some of the really awesome programs that my patients participate in, like going to the gym, doing silver yoga, silver sneakers, rock steady boxing, those haven't been open in many states. I'm in North Carolina, and gyms and the like just opened at partial capacity just 2 or 3 weeks ago. So some of those ways that we can help to stave off and maintain the bodies of people with Parkinson's have been taken away. And then more than just the physical, those are one of the big social outlets too. That, and then also other avenues for socialization, like in-person local support group meetings. And sometimes some of the groups have gotten up to speed with technology very quickly, but some it's taken a while. Not everyone's a technology guru. One of my local groups, it was just within the past couple of weeks, I was doing a talk for them, and it was the first time that they had had an online support group since COVID started, going on 6 months ago now, and they had been without that important part of the community. And that loneliness that I mentioned before, and it definitely is an aspect of COVID as well. So the graph in the lower left that you see, this was a poster that was presented actually just a couple weeks ago at the International Parkinson Movement Disorder Society virtual meeting this year. It was a really fascinating poster. They had a pretty large group of patients that they looked at and did questionnaires, and as part of a larger study, but trying to figure out what is the effect of loneliness. So one of the questions on this questionnaire is if people who endorse the statement, "I am lonely." And you can see the quality of life. That's what the graph is. The quality of life to the a bar to the left means that the quality in life improves. So there you see exercise. That's kind of like a control group. Like I said, we know exercise improves quality of life. And then on the opposite direction, then I feel stressed is one that decreases quality of life, people who have that belief. But even a greater predictor of a reduced quality of life are people who feel lonely. And COVID has definitely magnified that for everyone in society. And we can see this is some really fascinating preliminary evidence on there could be a significant effect on the direct quality of life of people with Parkinson's. So some takeaway messages, and here's where the hope comes in. I've always believed that the most important things that I give my patients are not by far prescriptions, but education and hope are the two most important things. So first, if you're struggling out there with balancing these roles, again, whether you're the care partner or whether you have the PD yourself, give yourself some grace. You're not Superman, you're not Superwoman, you don't have to do everything. I know it feels that way, that's what everyone feels, but you have to be able to engage your community. We'll get to that in just a couple of slides. And let it out. Don't hold things in. Holding things in for everybody just results in resentment and anger and bitterness. And get your emotions out. Communicate with your partner. Communicate with your family, your friends. And if you have trouble with that, which many people do, there's couples therapists and family therapists available. They may be psychiatrists, they may be social workers, they may be holders of other degrees, but there's a lot of relationship counselors that can be helpful. And some of them will not have experience with specifically Parkinson's, but some of them will. And but any sort of help with communicating. Sometimes I'll just, like I said, play the referee. I'll go back and forth and say the two people will be talking and an interaction doesn't go well, and I'll say, hold on, time out. What did you just hear the other person say? And I'll make them say what they thought their partner said. Turns out that's not actually what they said, but that's what they heard. There was a communication gap in between the two. And in the heat of the moment, when there isn't a referee there, those can get to be like a freight train and get out of control really quickly and end up in arguments and hurt feelings that may far outlast the initial argument itself. So the community that you have is no good if you don't engage it. So many of us in the PD community, we know that there are these resources out there, but sometimes it's harder than others to access them. But that's what I would encourage, is that make full use of every aspect of the community that you have, whether it's your church, the support groups, your family, your friends, and then expand that community and expand your treatment team. If the primary person or only person you're talking to about Parkinson's is your neurologist, maybe you would benefit from having a psychiatrist as part of the treatment plan, or a therapist, or a social worker, or multiple. physical therapists, occupational therapists, speech therapists, that, this list could go on and on, as that first slide that I stole from PMDA showed very nicely. There's a lot of resources out there, but you got to reach out and take hold of them for them to do you any good. And really make it a focus to maintain your relationship intimacy for people who are in a partner relationship. Now, obviously, that's important for every couple, but again, given some of the challenges that we've seen in the slide so far of how that can be with PD, I think it's especially important to make a concerted, proactive effort to do so. Schedule date nights, get couples therapy if needed. And finally, just remember, care partnering is a two-way street. So all the care partners out there, I promise you, if you take care of yourself, the person you're care partnering with will do better. And no matter how many times I say that to someone, how many ways I say it, I think nothing gets the point across better than this analogy. If you've ever ridden on an airplane with a child as a parent, and as a parent of 3 kids myself, every fiber of your being thinks to yourself, I need to put my kid's mask on first and save them. But the reason why it's recommended you put your mask on first, what if while you're trying to get your child's mask on and don't have it there on them quite yet, then you pass out from lack of oxygen, then neither of you have the mask on. So this statement, put your mask on first, is something I say to my care partners I work with all the time. Are you putting your own mask on first? Now, have you been putting your own mask on first? And once you understand this analogy, and hopefully this slide will, that you may have seen on some airline or another at some point in your life, will remind you of that when you get lost in thinking, I've got to do more, I've got to do more, think to yourself, have I put my own mask on first? So now I've got, this is the last actual content slide. These are these one quote case studies. The first 2 came from some of the families that they were set by the person who has PD. And then the next 5 lower down are from care partners. And I don't want to take up the whole rest of the half hour with presenting all these. I just put them up for the purpose of maybe stimulating some questions and discussion and seeing if it resonates with you. And if there are questions that you have about those, if you're dealing with an issue that is similar to one of these, please put a question into the chat box, and I'd be happy to talk through it a little bit further. So I think instead of going to the actual slide that says Q&A, I'll just leave it up on here, and you can keep looking at that. And I'll go ahead and let Anissa start pitching me some of these questions that you guys have graciously put in.
All right, you've covered a lot in a short period of time, and it's a very complex interaction between, your personality traits, your family dynamics, and the changes that Parkinson's can create. So I want to ask a question just from looking at your slide, and then I'm going to get to some of the ones that came in here. So this one here, the second one, my daughter won't let me see my grandkids because I can't stop crying. I've heard this several times before. Can you explain to our audience, like, what would cause someone to have the issue with uncontrolled crying, or any other emotion like laughing that might seem inconsistent with the context?
Yeah, absolutely. And I was hoping someone was gonna take the bait. I had some of those quotes I specifically selected to be thought-provoking of, oh my gosh, what does he mean by that? And that's definitely one of them. So there's a couple of different ways that this could manifest, but one, and you alluded right to it, Anissa, is that there's a certain neurological condition called Pseudobulbar Affect, and it can occur in many different conditions. It can be in Parkinson's, other neurodegenerative diseases like Alzheimer's, Huntington's. It could happen in people with Lou Gehrig's disease, who've had a stroke, who've had a traumatic brain injury. Many different neurological conditions can cause it. And what happens is that, we don't know exactly why, but that the person, without feeling sad, might have uncontrollable crying, either for no reason, or they might see something like a Hallmark commercial that's a little bit poignant and touching, but they start bawling, and their emotional response is very exaggerated compared to what you would expect. And then it can go the opposite way as well, that it could be laughing, laughing at things that are not funny or just a little bit humorous might make them normally just grin, but they laugh uncontrollably, or just laugh at something inappropriate, and it's uncontrollable. So that's one aspect, but actually the one that that quote stemmed from, it was from a woman who suffered from some pretty significant depression with Parkinson's disease. And she really couldn't stop crying because she was legitimately sad. And then in that case, that her daughter thought that she was emotionally unstable. She didn't understand Parkinson's and how it can affect the mood and cause depression. And she didn't want her mother's perceived instability to affect her children. And of course, that made the woman cry even more. She was devastated that she wasn't able to see her grandkids. So those would be two different ways that could not uncommonly manifest in Parkinson's.
And what kind of suggestions can you give to people in the scenarios where they have family that's resistant to being exposed to that and not understanding that?
So really, I think the best medicine there is education. And in that situation, I think in many of them that it's a misunderstanding and or lack of understanding of what Parkinson's is, and that it's not indicative of a mental instability or a character flaw or weakness or any of a number of things that I've heard throughout the years. That it's a neurobiological condition. It's a brain health condition. Nobody judges people who have diabetes, which is an illness of the pancreas. But many people with other illnesses of other organs, like the brain, that have depression, anxiety, other conditions, there's a stigma and a judgment, unfortunately, and that has gotten better over time, but it's still not very good, to be honest. And so I think in that situation, the person may not respond great to just giving them a book or something, but maybe finding bringing that person into a visit with one of the healthcare team. If there is a psychiatrist involved, that'd be great. I've fulfilled that role many times in the past, but a neurologist as well could very well fulfill that as well, of just explaining that this is part of the Parkinson's, and it has nothing to do with your parents' ability to be a good person, to be a good grandparent, and just correct some of those misperceptions.
Okay, fantastic. So we had a question earlier that came through in relationship to neuropsychiatric testing. You mentioned earlier, that cognitive changes can occur, and that certainly can impact a person's response to things. So apparently this one has had this done 3 times, and they never really revealed much in the terms of cognitive changes. However, there seems to be some issues related to executive functioning that the care partner can determine, even though the test didn't pick it up. Is there any research being done in terms of developing new tests? And what do you tell people when the care partner sees something that a test hasn't identified, but because they're with them all the time, they knew what they were always like before, and they can clearly see the differences? How do we deal with that?
Yeah, no, that's a great question. Thanks to whoever asked that. So neuropsychological testing, and just briefly for those of you who may not be familiar with that, so that is generally done by a doctorate level psychologist, and it's a multi-hour long test, part interview, part computer test often, that measures things like the attention span and the speed of processing that the person has, and a number of different other parameters, executive functioning being one, and tries to kind of boil it down to, in some cases, a number, things like that. But some impressions of their overall cognitive performance relative to other people their same age that are matched, so to speak, and trying to get a handle on, well, are they showing cognition that is roughly appropriate for their age? Is it slightly below what would be expected? Is it significantly below what was expected? And in which area? They might be able to remember things very well and give a great list of animals that all start with the letter M or whatever it might be. But executive functioning, which could be things like planning and executing complex tasks, planning a meal, doing taxes, more complex routines. that could be impaired. So overall with the testing, then I think one of the best ways to kind of place it in its usefulness is giving some benchmarks over time to look at change. That it's, even though it's a multi-hour test, it's still just a little sliver of time, less than a day. And the care partner spends potentially up to all day, every day with this person. And there are things that the tests just aren't designed to capture. One analogy I might use is that a biopsy for cancer. They take a little needle and stick it in. They usually do it a couple times if there's a suspicious mass to see, do we find any cancer cells? And if it comes back that it does have them in there, definitive that there's cancer. But if the biopsy comes back as negative, well, maybe they just didn't hit that part of the mass that had the cancer cells in it. We can't rule out that there is something more serious going on, and that's I would say probably how I might look at it in this situation. Obviously, I don't know specifics, and please talk to your healthcare provider, whoever that is out there, and ask about that very question of why is this? But that would be kind of my suspicion, would be that there's the tests are designed to capture a broad range across the population, but everyone is so different that there's no way for one specific standardized test to capture every single thing that's going on with Parkinson's. So we can't bank everything on a test. They're useful, but they have to have the limitations considered by everyone involved.
Okay, thank you. All right, and one person said they do best when they have the same routine every day. So how can they convey to their family members in another city that traveling to see them for special occasions can be difficult? Disrupting those routines can be difficult.
Yeah, no, that's a really good question, because that's one that I've had that before with people, and the family members usually interpret it as that, oh my gosh, I can't believe it. They don't care enough to make the trip out here. They're making an excuse that they don't want to come. They're just lazy. I've heard before things of that nature. And in the situation that you're describing, this, nothing can be further from the truth. So yes, that is definitely the case, that for many people with Parkinson's, especially as it becomes more advanced and shared with other neurodegenerative disorders like Alzheimer's, then that disruption in the routine can be very destabilizing. That there's that the ability to be flexible and adapt to situations, it gets a little bit more difficult with these neurodegenerative disorders, and that can significantly throw off the routine. I've not seen as much written about it in Parkinson's as I have in the Alzheimer's literature. So that actually might be a useful way to go about it, because I think there is a decent understanding in most people in the public about how those changes can be difficult for people with Alzheimer's. Or certainly, a book or pamphlet could help convey that, and that could be one reference. But again, just bringing in those people, especially now with telemedicine, I've been able to have even just very brief family interactions that I never did in the office. There could be a child who lives many hours away. They could have never made it to an appointment in person, but I can add them into the Zoom call, even if it's just for 5 minutes, not for the entire length of the appointment. And that would be a great opportunity. Can you hop on the Zoom for like 5 minutes with my doctor and let him explain it to you? That could be another way to look at it. So again, it's education.
Yeah, very helpful. Okay, so there's a few questions that seems to be surrounding maybe adult children. So another person wrote in, their already stoic husband, premortally, has become even less emotive, and it's affecting relationships with their children. And so whatever their response is, it seems as it's perceived as being disapproval. And it's very sad for this person. So what kind of suggestions do you have for people that are dealing with the blunting maybe of emotions, and how to explain that to family members?
No, that's a great question. It speaks back to the facial expressions that I mentioned before. There's actually a really interesting study that was done a number of years ago, where the people with Parkinson's were filmed and then shown to some some volunteers for a study didn't know what was happening and compared people with Parkinson's that were filmed to people without Parkinson's. And the subject participants who were in the study judged the people with Parkinson's because of, in large part, the facial lack of expression as being less intelligent, less friendly, more hostile, a number of different very negative adjectives. And actually, even in the medical terminology, the expression of people, this would generally refer to the unmedicated state in Parkinson's, is the reptilian stare. I mean, they really need to change that because that in and of itself is judgmental, in my opinion. But just the way that I jokingly say it is that don't ever try and get into a staring contest with someone with Parkinson's. You'll never win because they have a hard time blinking. So that's exactly kind of what you're speaking to. So it's harder in the situation that this person described in this because the person is naturally stoic to begin with. So some of the common advice that I would give in that situation is that the person maybe can be a little bit more proactive in saying, I know I don't look like it, but I'm really excited about that job promotion that you got. Or, I know I don't look like it, but I think that was really funny. And that for someone who is naturally pretty reserved and stoic can be a little bit difficult. But that doesn't mean I wouldn't encourage them to try it, to work on that. Everybody can always improve on certain things that they have trouble with. But again, it goes to speak towards the letting the person know that you don't have to be a very flowery, expressive, emotive person to say, or to write out a statement saying, I'm not showing very much facial expression, but I want you to know that I still love you and I'm proud of you. And especially maybe the written part of it, that might be, one thing. So one thing that I've done in the pandemic is instead of, if someone's Zoom turns on and it doesn't have microphone and they're not connected to audio, I have these little flashcards made. Say, you have to connect to audio. Try logging out and logging back in. That could be something right there. They could have the more expressive care partner make up some 3x5 note cards that say things like, way to go, you rock, I love you, I'm proud of you, things like that. And they could just hold up one of those flashcards. That would be something that wouldn't, I would think would be a little bit less threatening to the person doing it, and would definitely get the message across and certainly collect some smiles, and I see some smiles in the audience too. So sounds like I came across a good idea there.
I love that idea. That's awesome.
Thanks.
That's a very practical and fun way of managing that. That's awesome. All right, so on to another question. Can you address the issue of when the care partner wants to take over for the person with Parkinson's because they don't do things as rapidly as they used to? And I think this is a two-part thing. Because one, it kind of takes away from the abilities of the person who's diagnosed to continue to do things for as long as possible. And, they want to be able to feel a sense of accomplishment. And then on the other hand, it adds to the list of things that the care partner has to do on, to their already growing list of things. So what do you say about that?
Yeah, absolutely. Very common, and that does really have a lot of damaging effects for the person who's diagnosed. Then they come to feel that, well, maybe I shouldn't. And again, this often comes up in terms of speech and speaking rapidly enough that, well, I get so frustrated. People always finish my sentences for me because I can't say it fast enough. So I'm just not going to say anything because I don't want them to feel obligated to do that. So yeah, it is very complex there. And even more so, I would say another layer would be not just not doing things rapidly enough, but what about cognitively? When does if the person who's diagnosed is the one who normally does the taxes or pays the bills or whatever, when do you start to wonder, well, is their cognition good enough at this point to be able to continue to do that? Do I need to take it over? Also, again, to try and inject a little bit of humor because it's not all doom and gloom, also that makes arguments really hard. Do you really not remember that because of the Parkinson's causing memory problems? Or are you just saying you don't remember that? Things like that. But so the actual advice I would have is that that would really go towards, well, two things. One, telling the person who's diagnosed that you stand up for yourself. If it's something that you can do, but it's a little bit slower, advocate for yourself. And fortunately, that was what I love about working with people and their families with PD, is that they are great advocates for themselves generally in most things. But then also for the care partner, that explaining that the effects that it has on their partner, because in most of those circumstances, while I've run across it, they didn't even think about that, because like you said, they thought they were helping. They thought that the other person was getting frustrated and they were getting angry at themselves for not being able to do it. And sure, they might be having some frustration, but then when they achieve it, it's a sense of pride of, I did it, I beat that. I beat the Parkinsons in that moment. You know, long-term, nobody wins against Parkinson's, unfortunately, but in that moment, I beat it. I was able to do that thing, even though it was hard. So I think kind of explaining that to the care partner, and that how much that means to them, and that it can have ripple effects, like I said, on other interactions, because if their care partner is thinking that they're not good enough to be able to do that task, of course, the person who's diagnosed is going to think, well, then my friends, my coworkers, my kids, they're going to assume I'm not good enough either, because, you know, if my partner doesn't think I'm good enough, you know, that's always been my number one fan. If they don't think I'm good enough, nobody would. So in my experience, when I've kind of talked through these hypotheticals, then I see that light bulb go off on the care partner and say, oh, I never thought about that. And they turn to their loved one and say, I'm so sorry. I never meant to do that to you. If I'd have known, I never would have done those things. So fortunately, in most situations, it's generally fairly easily correctable. You know, sometimes people get into routines and it's hard for them to stop themselves. So it may take some reminding to them over time that if it happens a couple times, it might be okay, because they're just learning that new routine. But really talking through, and again, playing kind of like that that referee, or the bird, me having the bird's eye view, or another person on the treatment team having that bird's eye view, can make a big difference, because it's so easy to not see the forest for the trees with Parkinson's.
Okay. We have lots of really good questions. I'm going to go to one in regards to the team. And there's several people that wish they, just like I said, wish that they could clone you. And how do they find someone like you?
And how I got interested in Parkinson's. So I, a number of years ago, there's certain drug-induced movement disorders that can happen as side effects from many of the meds I prescribe as a psychiatrist. And through that, I became connected with the greater neurology community in Charlotte. And once they saw that there was a psychiatrist who was interested in Parkinson's, and enjoyed working with people with Parkinson's, then they started sending me all their Parkinson's patients for depression or anxiety. And then they started to see, wow, this really does make a big difference in my patients' quality of life. So I wish someone like me, maybe not me, you know, my wife would say that there's no way the world should have any more than one of me, because I'm enough to handle as there is, but someone maybe similar to me would be wonderful to have all around the country.
So this person in regards to the team was their son is an early onset or young onset PD person, and they're struggling with getting the physicians to work as a team, just getting everybody coordinated as a team, because not everybody has access to kind of that one-stop shop of, you know, the team all being in a building or easily accessible. So how do you recommend people advocate to get there to be more of a team approach to their care, especially in regards to these kind of issues?
You know, that is such a great question, because I almost launched into a little bit about this with my last response. So, you know, fortunately, the neurology community in Charlotte, they have been really great about that. You know, I've got the cell phone numbers of half the neurologists in Charlotte, and we'll call each other, text each other if we have something, a question to the other, and we do stay in contact. And yeah, the patients, their families, when I tell them, yeah, I was talking with your neurologist the other day in preparation for this, and what we thought was their mind's blown. Like, oh my God, my doctors talk to each other? That never happens. And that's extremely unfortunate. And it's difficult. So I'm in an individual private practice. I work for myself, so I call the shots. I make the rules. Most, I would say most movement disorder neurologists certainly generally work for one of the larger healthcare systems, and they're not their own boss most of the time. And they are told how many patients they have to see per day, so on and so forth. And if the healthcare system isn't getting compensated for the time of that phone call, then that's something that the healthcare system might say no. You can do that on your own personal time, and that's hard. So, first, certainly just appealing to the physician or other provider and say, look, I know it's hard being a doctor, but it's hard being a care partner. It's hard having Parkinson's too. Do you think you could just spare a little bit of time and talk with my internist, my psychiatrist, my therapist, whatever, and maybe get creative. Again, use some little judo or jujitsu, use the momentum of COVID to our advantage. Schedule an appointment with your neurologist and schedule an appointment with your primary care doctor at the same time, and then put them on Zoom with each other. Right there, they're both getting paid for their time by being able to build the appointment. And then you say, put one phone next to the other on Zoom and say, all right, you guys talk now. I'll be right here. Sometimes you have to get a little bit creative with your advocacy to shake things up. And I bet after that point, then they're probably going to pick up the phone and call each other on their own after that, once they see the links that you're willing to go to get this to happen.
Okay, I really love your out of the box thinking.
Thank you.
It's awesome. Okay, we've got some really great questions. We could probably be doing this for a couple of hours. Okay, a couple of them that I really want to try to get to. So one person wrote in, and I'll tell you both of these. And one is about having to deal with a person who is diagnosed and is in denial. So they were diagnosed at age early PD, and at age 75, they're in denial of their symptoms. What do you do with denial? How do you help? If you got the care partner, you got one person who is accepting of it and wanting to deal with, managing the symptoms, and the person that's in denial and does not, the patient.
Yeah, so gosh, there's so many follow-up questions I would ask. Didn't know about what exactly. One of the common ones that I see is in denial about their inability to drive. That one comes up all the time. That, oh no, I'm perfectly fine driving. I don't have any problem driving. That's a tough one, but it might be more broad than that. Just they might be in denial of everything, of any symptoms. Parkinson's would be one that I would think be difficult to be in total denial, because that one, the evidence is right in front of you at some point with progression. But really, it would kind of depend on what specifically they're in denial of. And then once we figure that out, then using techniques from a branch of therapy called motivational interviewing. So it was initially designed to pretty much be used for people who are substance abusers. And they have denial about the problems that their substance use is causing their life. And these set of approaches are useful in dealing with that. And the way that works in a nutshell, there's whole textbooks. I think I have at least one up on my shelf back there, but pointing out some of the inconsistencies. So you say that your goal is this, but the actions you're taking, are they leading to your goal? Are you going to achieve that based off of the actions that you're having? No? Well, then what is it that's making you do that action? So something along those lines of, and the most important thing about motivational interviewing is that you cannot be critical and judgmental. That because then it just becomes kind of you being a jerk to the person. So that's the most important thing. It's really coming at it with a sense of curiosity and wonder. Like, explain that to me. To use the substance abuse one. So you say that that marijuana is your best medicine, but you keep ending up in the psych hospital from smoking marijuana. How does that work? Now you say that there's no problems with it, but you've gotten arrested and lost your job because of the DUIs. How does that happen? Something along those lines. So again, it'd be hard to give more specifics about knowing what they're in denial of, but just trying to, with a sense of wonder and curiosity, get them to explain, because it's hard to defend something that you can't defend. And when you point out those logical flaws or fallacies, then the point is to try and make the person convince themselves, because you may not be able to convince them, they have to convince themselves. And this is a tool to kind of pull them or lead them in that direction. So look up motivational interviewing techniques. You don't have to be a certified therapist in it, but some of those approaches I think could be helpful for that person possibly.
Awesome. All right, we have time for probably one more question.
Okay.
I think this one's an important one. So this person says, my partner gets fixated on activities and projects such as jigsaw puzzles, staining furniture, and is extremely difficult to get him to change course. When we have to go places or do things, they become very frustrated, but the psychiatrist told them to only push hard when it's a safety issue. Yeah, so what would you say when this is becoming a problem multiple times a day and can't get them to do anything else?
Well, so there's a lot of things that are coming to my mind, and yeah, I see we are getting close, so I'm going to try to be brief. I think one, you have to pick your battles, but it depends on what it is. If it's jigsaw puzzle, then that might not be as bad as a safety issue. But what if it's one that's come up in my practice, someone who obsessively shops online? They would buy unbelievable amounts of things because they would obsessively research and just buy a ton of them. And things of that nature, or getting obsessed with pornography or something else. Not technically a safety issue, but it's important. So I think you have to have a spectrum of responses, but also what is the kind of pathology underlying that? Is it that they're having some OCD-like symptoms that could be treated in the vein of treating someone with OCD? Is it that they might have ADHD? People with ADHD, it's not that they can't focus on anything, it's that they can't direct their attention to where they want it. So the parent who says, my kid can't have ADHD, they can focus on that video game on the Xbox for 9 hours straight, that's part of it, because they can hyper focus on something to the detriment of other things around them sometimes. So that could be a possibility. Someone could have comorbid, long-standing ADHD and later in life develop Parkinson's. It could be related to the medications. Some of the dopaminergic medications can have can cause that impulsive compulsive behavior, excess gambling, spending, things like that. So that could be something that could be a medication adjustment. So there's just so many possibilities there. The two most common answers I give in life, I think, are it's more complicated than that and it depends. And neither my wife nor my patients like those answers, but that's just how it is.
Right. All right, so this has been excellent. I think that we could probably go on and on and on, but
I agree.
unfortunately we are at the end of our time together. So I want to thank you so much for your insight, some of your real neat and out of the box ways of addressing these issues. And we might have to do another follow-up because this seems like a very popular topic. So I appreciate your time today. Thanks for
I would
doing.
love to. I appreciate everyone who logged on today. Thanks for asking your great questions, and stay safe and take care of each other out there.
Right. And for those of you who do want the slides, they will be available if you want to email us at info@pmdalliance.org. This will also be up on our YouTube channel. So if you want to rewatch it or share it with your family, this might be a good way to explain some of these things. Feel free to do that. So let's wave goodbye, everybody. Enjoy the rest of your Wednesday, and we will see you next time. Thank you.